So next on our agenda, okay, these heels make me a little taller. Okay, so next on our agenda is the work groups. And I just wanted to talk a little bit about what we did in the summit the second year, which was last year, is in order to continue the conversation and work throughout the year, we developed these work groups, which you'll experience this afternoon. And earlier you heard from Dr. Cabral, who gave you an update on the research work group. So after we have updates from two of the other work groups, one from Dr. Dumois to talk about the early detection work group, and then Dr. Kevin Sherin for Prevention and Awareness, this afternoon after lunch, you will have the opportunity to join one of 4 different work groups, and there may be 5 this year. There are 5. And most of those work groups are on this floor, but there is one on the second floor. So awareness and prevention will be right here in this room. Early detection, treatment, and research will be across the hall, and there will be posted the room numbers on the screens behind me during the lunch hour, so you can see which rooms those are located. And then on the second floor will be laboratory awareness and detection. So during each of those work group sessions, you will receive presentations from subject matter experts in each of the areas. And then you can also sign up, or you will have the opportunity to sign up for virtual work group or conference calls throughout the year, so you can participate in being part of the team here. So at this time, I'd like to bring up Dr. Juan Dumois to talk about what's happened in this past year around early detection.
Thank you. I'm just going to try to go quickly through this and not give you much preamble, except if you haven't gotten the message so far, early detection is really important for survival of the patients. I think I've heard it about 5 times today. So that is the focus of this work group, in how to encourage early detection. So the work group started meeting at the summit last year, and then worked for several months to try to develop this algorithm. This is the original version of the algorithm, and you saw a slightly modified version in Dr. Kirby's presentation, the one that they've actually implemented at Florida Hospital. What I'm gonna try to do is spend just a little more time walking through the steps of the algorithm. So, first is a lumbar puncture is being performed for suspected meningitis. There are other reasons lumbar punctures are performed. For example, many patients with cancer get lumbar punctures performed as part of the monitoring of their chemotherapy, and we obviously don't need to be looking for amoeba in their spinal fluid, but the focus is on kids being evaluated for meningitis. We wanted to include collect at least 4 milliliters because 3 milliliters is sort of the typical way it's done, because the lumbar puncture tray comes with 3 or 4 little test tubes, and the convention, the way doctors are taught, is 1 milliliter per test tube. But the more we have, the more testing we can do on the spinal fluid. If that spinal fluid is obtained, the CSF is available, we order the CSF studies. And the studies will include the standard cell count, glucose, protein, a gram stain, and a culture. Those are routinely ordered everywhere. What we want to do is to remind doctors to think about looking for amoeba if the patient has had some water going up the nose, fresh water up the nose. But we don't always get that CSF. It's not always available. So we decided to include this part of the algorithm. Either it was an insufficient quantity, or it was collected at a referring institution and they didn't bring the CSF with the transport. And if it's anticipated that there would be any delay in bringing that CSF on or after the transport, we may want to consider repeating the lumbar puncture, possibly with the assistance of the interventional radiologist, especially for the larger children. If the CSF is available, if the patient is under 6 months, this would actually connect over here. There's a missing arrow that would be to do routine CSF studies. The intention there was to try to put in some sort of age range where maybe we're not as concerned for amoebic encephalitis, and we just almost arbitrarily chose 6 months because children under 6 months of age are less likely to have that sort of freshwater exposure up the nose. However, there was a reported case of a 1-month-old baby, I can't remember, it was either Pakistan or Bangladesh, that had been bathed in river water that had gotten up the nose and developed PAM. If a patient is over 6 months of age, then the electronic medical record will provide an alert to the physician to ask about freshwater exposure. And the mandatory question was worded as, did the patient have recreational exposure to fresh water, parentheses, lakes, streams, hot springs, pools, or tap water, to help eliminate the often lack of information physicians get in medical school about what types of bodies of water can contain Naegleria. We're often taught it's just ponds and lakes, but it's not. Or perform nasal irrigation with tap water, because that is a potential source. The answer would be yes, no, or unknown, and at Florida Hospital, it's a mandatory field that has to be answered. If the response is no, then you just do the routine studies and empiric antibiotics. But if the answer is yes or unknown, then we proceed to an automatic message or order to the laboratory for a wet mount and Giemsa right stain, as you heard Sheila Black describe the methodology. A stat evaluation by the tech or pathologist, and at Florida Hospital it's both. An order for the Naegleria PCR to be sent to the CDC, and look at Appendix A, and I'll show you Appendix A in a couple of slides. If it's negative for amoeba, you just go on with the routine evaluation, but if it's positive for the amoeba, we'll contact everyone that needs to know about this to expedite the beginning of the treatment. Infectious diseases and calling the CDC hotline. We've got the hotline number in there, calling the ICU, looking at the medication orders in Appendix B that I'll show you. Consult neurosurgery for placement of an intraventricular catheter, because that's one of the ways we give amphotericin, one of the medication choices. And then consult neurology for prophylactic anti-seizure medications. Now on this next slide, it's a different version of the same algorithm. And this version was created for our hospital based upon a recommendation of our information technology physician. And she just had a minor recommendation to change that the alert would come if someone did not order an amoeba test. It's a minor difference, but she thought that the way Cerner works at our hospital, that it would work better. So the main point of even showing this, and I'm not going to step through it, is that the main guideline can be distributed to hospitals who would review it and then modify it as it can be best applied in their own hospital, as we saw on the Dr. Kirby's slide for Florida Hospital, where they had a few modifications of who needs to be called. FHO, I don't even know what FHO or FCO, but still, they know what those abbreviations mean. They know who needs to be called at their institution. So Appendix A lists the lab procedures, and most of this information came from Dr. Ali and Dr. Cope from the CDC. And then Appendix B is clinical management. Appendix A, the first half of it is a description of how to do the wet mount of the CSF. And so we heard some of these details in Sheila Black's presentation. I won't spend more time on that. But moving on to the second half of Appendix A is the description of the right stain, and then the specific protocol on how to send the CSF to the CDC in Atlanta for that PCR, including addresses and phone numbers and emails to be sent. Appendix B starts with management, and the first small paragraph is the non-medication stuff. So I'm gonna have to turn around on you again and read that, because I can't read it way back there. Maybe I need a new prescription. But first is monitor and manage cerebral edema. And that's what Dr. Liriano was doing and talking about in his presentation. As soon as he got the call, he knew what he was going to set up. And that may include, oops, sorry about that. here we go. Hyperventilation and a goal PaCO2 of 30 to 35, hyperosmolar therapy with saline and mannitol, induced moderate hypothermia down to 30, so cooling the patient down from a normal 37 to 32 to 34 degrees, and a prophylactic anticonvulsant. Consider the use of an induced pentobarbital coma. The intracranial pressure goal is less than 20, and a lot of these guidelines, which are actually the recommended guidelines for managing these patients listed on the CDC webpage, came from some of the initial work developed by Dr. Leinam, who's here in the audience, with a case several years ago. Then place a nasogastric tube for miltefosine administration if they weren't already able to take a pill before being sedated and made unconscious with all these other interventions. The next part of Appendix B has the medications. So we give amphotericin, what's normally considered an antifungal medicine that also has in vitro activity against Naegleria, both in the IV form, but then also it's administered intrathecally through that access acquired by the neurosurgeon. So the neurosurgeons know at our institution that if we call them, that they will be available to immediately place this instrument. Then we give IV or oral versions of azithromycin, fluconazole, rifampin, and then miltefosine, that's an anti-leishmania parasitic drug that also works, and we want to give that to these patients. It used to be that we could only get this drug by calling the CDC and having it flighted overnight. But now we have the ability to stock it in pharmacies, and it's quite easy for the pharmacies to stock it because they aren't even charged to stock it until the medication is used. So we now stock it at our hospital, and I know it's stocked at Florida Hospital here in Orlando. By the way, my hospital is, I'm in St. Petersburg, Florida, just on the west coast of the state at Johns Hopkins All Children's Hospital. And then dexamethasone is given IV for its anti-inflammatory effect. We have several footnotes to that medication table, with the first footnote giving some more information on how to administer the amphotericin, specifically that we want to give the old standard type of amphotericin because it seems to work better than newer versions of the drug that are bound to a lipid. There's often an interest in using the newer versions because they are less toxic to the kidneys, but they're less effective. So we want to use the more effective one. That may have been one of the reasons that Sebastian had some temporary kidney damage from his treatments. The second footnote is kind of interesting, and there was a presentation at the summit last year by Dr. Jordan in which he described the results of an in vitro study of another antifungal called voriconazole that is similar to fluconazole. It's in the same family of medications. And in vitro, it might work even better. In the test tube, it might work even better than fluconazole, but it's never been tried in a person. So it's a consideration. We're going to put it there as an option, and it'll be up to the discretion of the clinicians whether they want to use voriconazole or fluconazole. And then the third footnote is more information about miltefosine that I mentioned before. And for hospitals that don't stock it, it's got the phone number of the manufacturer distributor Profounda on how to get it as quickly as possible. We have some references that I don't have to go through in detail, and I'll just end it there. Are there any questions about that? We'll be talking more about future moves for this protocol in the afternoon workshop. The main thing that we want to address next is how to distribute this as widely as possible to as many emergency centers as possible so that doctors will really think about it. Just 3 days ago in our hospital, I was consulted to see 2 different children who presented on the same day with acute encephalitis. And unfortunately, I was the first doctor to ask the family about fresh water exposure. And fortunately, neither had that. And we've already come up with some causes for each of their cases. But we have some work to do at our own institution. Thanks for your attention.
Thank you, Dr. Dumois. Next, I'm going to ask Dr. Kevin Sherin from the Florida Department of Health in Orange County to come up and give us an update on the Prevention and Awareness Workshop from last year.
Thank you, Donna. So my task is to maybe one of the few people standing between you and lunch, perhaps the only person. So I'll try and be brief. You heard the summary that I'm going to update you on the Prevention and Awareness Workshop and what's been done since last year. So I have no disclosures. And you heard the quote that came out of the Florida College of Emergency Physicians meeting, but I do use it all the time. It's one that I learned in medical school, and I think everyone who's been to medical school has probably heard this quote. And it's true. The diagnosis not thought of is the diagnosis not made. So Naegleria fowleri is found on every continent except Antarctica. That's a true statement. So we want to increase awareness, and we want to increase the prevention of Naegleria fowleri infection. And that is the purpose of the workshop last year, and we'll try and summarize some of the activities that have taken place. So one of those was to be working with the Florida Medical Association. And like Dr. Dumois, I have trouble reading the slide from across the room, and with the bright lights in the eyes, it doesn't make it any easier, especially when you have these, progressive lenses that come with age. But I can tell you the story better than I can read the slide. And the Florida Medical Association had a meeting in Tampa, I want to say January of this past year, 2017. And I remember going over there and speaking to their continuing education committee of what activities we might be able to propose. So with the support of the Orange County Medical Society, we were able to introduce the topic. And this followed on a resolution that was submitted the previous year in 2016 for increasing awareness of prevention in the state and talking more about the diagnosis and treatment of PAM. And there was interest on the part of the Florida Medical Association, and there were laboratorians in the room as well. So that was a fruitful conversation. It has to work its way through the various levels of the organization within the Florida Medical Association. But we were fortunate that within the annual meeting, there was a panel discussion on emerging infections, and we did have this topic, and I was able to present at the annual meeting here in Orlando in August. So the Florida Medical Association had a workshop on emerging infectious diseases, and similar content to what you've heard today, we were able to present as Category 1 AMA approved credit, where a number of physicians from throughout the state, and in fact other states, physicians from other states do attend the Florida Medical Association's meeting, because after all, it is Florida and people come here on their vacations. So that was here at Orlando. That was approved by the Board of Governors back in 2016 from the original resolution. It was adopted as their policy. The American Medical Association similarly had a resolution. I submitted it through another organization of which I'm a past president. I'm a past president of the American Association of Public Health Physicians. So that organization submitted this resolution to the American Medical Association, and it supported two things: CDC training and education efforts relating to PAM and clinical guidelines and standards of care that promote rapid diagnosis and effective treatment of PAM. That was adopted as policy of the American Medical Association House of Delegates. And so that continued forward in their pathway. So we hope that there will be, national efforts to also increase awareness to physicians. And we hope that, not only what's happened with the Florida Medical Association could have uptake that goes forward with the AMA, it's possible, but what happened also with the Florida College of Emergency Physicians, which was done in the spring of this year, could have uptake that goes forward. The CME track on August the 5th was entitled Emerging Infectious Diseases in Florida. The specific track on PAM was Getting the Advantage, and that was the publication of that, which is available from the Florida Medical Association. This was the presentation to the Florida College of Emergency Physicians, also done by me in February of 2017. And this was a live webinar. It went to about 100 people in the state, and the Florida College of Emergency Physicians is looking at making this available to the American College of Emergency Physicians. And with the support of the foundation, thank you again to the board and to the Smelski family, it may in fact happen. If there's sufficient support, and with the help of the Florida College of Emergency Physicians, this webinar can be supported for another year. It will be available, and if the American College of Emergency Physicians so chooses, it can go forward to 4,000 members of the ACEP who make use of that material. But again, it's an entire review of the recognition, the clinical diagnosis, the algorithm, which Dr. Dumois has just showed you, the laboratory diagnosis, the clinical presentation, the clinical treatment, and the critical care aspects. All of it's packaged in there. This is what I delivered in all the different settings. I don't know if we're even mentioning in this particular slide set that I also spoke live to the Florida Academy of Family Physicians in April of this year, live audience of about 150 or 200. This was a recorded webinar, of course, with the Florida College of Emergency Physicians, and it's available for playback. So we're planning to make this available, again, with the help of the foundation. We do hope it goes forward, but there's no indication at this time one way or the other what's going to happen. These are more or less planned activities that can occur. And the idea is that you will have more uptake, you'll have more dissemination of these materials, just as with Sheila Black's materials. That's had uptake within Florida hospital system here in Central Florida. It could go wider within the Florida hospital system. I don't want to speak to other people's material, but the idea is greater dissemination. When you have best practices, when you do learn new information, how do we as healthcare professionals disseminate that and see that the standards of care and the practices improve in other areas as well? So here's a quote from Henry Ford, and it really has to do with that adoption by others, if you will. Coming together is a beginning, keeping together is progress, working together as a team, if you will, is success. So what has happened as a result of the summit for the last 3 years? You've had collaboration across hospital systems, with the CDC, with the Smelski Foundation, with other foundations, with health professionals, really truly from across the United States, involving other professional associations and organizations here in Florida and elsewhere. This is really attributed to Edward Everett Hale, and yet I know that Henry Ford used the very similar quote. So we leave you with these thoughts, and it is all about teamwork. How can we continue our work together and have this success? It is working together as a team. Thank you.